These videos are learning materials for the London Enhancing Generalist Skills programme. They're related to the programme domains of social justice, person-centred care, systems working, population health and sustainability. In this video, Martin Griffiths and Roisin Keville explain how they've aimed to create a hospital without walls and have transformed the ethos of the Royal London Trauma Service, improving outcomes and lowering readmission rates.
Martin, could I start with you? What is a hospital without walls?
It's a community, isn't it? I don't think that congregating care in a physical space is the solution to wellness. It's a solution to illness. But what we as clinicians should be offering is a support to communities and individuals to own their care, own their solutions, and provide guidance and support. When we get our healthcare right, we have a living, breathing community that understands its relationship to society, to well-being, to community, and our role as in service is to make sure those individuals are aware of their health, what good health looks like, and provide the support and advocacy to access health in an equitable, deliverable, and positive way. The walls are never important. The Royal London story is an example of what we were trying to achieve. We recognise that individuals who have been injured in traumatic injuries require great physical care. But the real journey is to try and offer something more than that, to offer emotional support, to offer psychological support, and also offer a different direction, to offer a situation where that individual can be gripped by a support network that understands their needs, that delivers solutions that work not just in the hospital but in the community, with ongoing care, that delivers a tangible change in behaviour, and outlook and power to that individual and that family, that goes from the hospital into the community and is deliverable in that space in real time in a way that actually is tangible and robust. So what we might start in certain environments isn't how we continue them. We want to put the power within the individual rather than the institution and see where that takes them. And we will see individuals who would come back, time and time again. I remember seeing people would welcome me in the resus bay. I haven't met them before, I haven't operated on months or years before. Our readmission rates were ridiculous, 35-45% over 5 years. And these are young people, 16-year-olds, median age 16-year-olds. So children we were seeing. So we needed to do something better than just preach or shout or tell or give advice or signpost or refer. We had to make tangible change with that individual at the time of admission and do something that actually would last into the community. And more importantly, I recognised that our current mechanisms of psychology and support and preaching and teaching were not working. We had to have a different solution that connected with that individual and that family in real time and was consistent. It was forgiving. It was nurturing, and it was happening in an ongoing fashion. Develop a relationship rather than just offer advice, and that's where Roisin and the guys come in.
Can you describe your model? The model that you set up.
I think describing a model I can describe the original model, what I thought up in my head, which was about a needs assessment and providing a practical support and perhaps ushering into areas of support like housing and education and training. However, the joy of the model was it was broken on day one because the real needs of the individual exceeded my expectations, my knowledge. It wasn't about what I felt should happen, it was about what needed to happen. And what I realised very early in the piece is that my model was right for me, for middle-aged, middle-class bloke. It didn't work for young people who were in the grip of this difficult scenario. So what I said is let's let the model evolve, and I'll provide the bandwidth around it to make sure we cover the eventualities and make sure we have some oversight for it. And we'll let the case managers and we'll let the individuals shape the process for each and every individual in a tailored way. And that's why it works.
Roisin, can I invite you to come in now? Because I think you were one of the first caseworkers. Can you tell us what happened?
So I was really happy and excited to, get this off the ground. And myself and Antonia, who started, she was a very seasoned caseworker. And I myself came from a clinical background previously, having worked in the cardiothoracic centre at St Thomas's for almost 15 years. So the combination of my clinical experience and in that environment and Antonia's long extended caseworking experience really married up very nicely. But neither of us really we couldn't foresee or even predict or imagine really and truly what we was actually letting ourselves into. And we was eager to hit the ground running, and we literally did. And it has not stopped in just over 7 years. There's been no let up. It's been relentless. We were welcomed, we were supported. I know there was some, reservations, because this was the first of its kind. There's similar services, but this was the first of its kind to be embedded within a ward and within the trauma department. And yeah, we started meeting young people and introducing ourselves and offering this tailored wraparound support. And I think because me and Antonia wasn't in a uniform, what we've done is we've literally taken the SOS model, which was being delivered in the community, which was a gang exit program originally. We took that model of wraparound, not judgmental, holistic support, and basically embedded that into our practice and the service that was being delivered at the Royal London in the trauma department. And young people engaged, and parents were so grateful. We've seen some horrific. I've seen some horrific things, and was exposed to so much, but the good so outweighs, the negative of what you're exposed to. Because I think what Martin realized is that when a young person is, put in these situations where they've gone through this traumatic experience, we know, because of the, Martin and his team and the nurses, they physically heal them. But it's the emotional trauma that leaves the long lasting effect, which derails these young people. Me and some of my colleagues and my friend, we were talking about emotional trauma even before I got into this line of work, because we recognize that, events in life leave little dents in us, and they leave its mark. And sometimes that ripple effect, it impacts on our behavior, it impacts on our choices. So, what was realized very early on is that when a young person becomes a victim, the risk of them becoming a perpetrator just shoots through the roof because of the emotional trauma.
Listening to you, I'm kind of wondering, what has this got to do with healthcare? Isn't it enough just to train doctors to be kind and empathic and competent? What you're describing, isn't it social work rather than healthcare?
Well, these people are presenting in our hospitals and in our clinical environments and at our GPs up and down the country, aren't they? So how can, Martin, he noticed this from being a trauma surgeon and seeing these kids coming back and coming back. And, it's like if you have someone who's overweight and they've got a lot of fat around their belly and are of a certain age, we know they're going to be at risk of diabetes and heart disease because of the fat that's surrounding most of their organs in their body, yeah? So as GPs and as clinicians, what do? You provide support. You provide advice. You try and reduce the risks by giving, dietary recommendations or referring to a dietitian or recommending exercise. So we do all of that with the physical element of, what we recognize. But why not when young people present with mental health issues, struggling in society, being bullied, being victims of serious youth violence, being exploited?
I'm sort of wondering what difference it's made having this model of caseworkers where I think you follow the young people and families up for quite a long period of time.
Yes. So we don't have a time frame, because we recognize, because of the nature of what these young people have gone through and the impact emotionally it has on a young person. And you think when a young person is being a victim of serious youth violence, Directly next to them is their parents, is their siblings who are impacted by this traumatic event. So we know with the right support, we can, support these young people and their families to not let these negative events derail them.
How do you reach these young people?
Sometimes it's about coordinating at the time of admission and working with the professionals from their communities, from their local authorities, to identify needs and ensure risks have been reduced and safety measures are put in place. And we've got some protective factors. And, we're caseworkers, but I'm starting to change that narrative where we're caseworkers, but also coordinators, because we are at the point of contact with that person in that moment, just after they've been stabbed. And we are often the person who the young person engages with the most. And I think because we are genuine, because we genuinely care, young people suss us in 10 seconds, and thankfully we're all trainer people and we're quite cool like that. So having, a nice pair of trainers on our foot is often a common denominator on music. And, we just treat these young people as we would wish to be treated. I'm not saying no one else does, but we take away the tick boxing, the agenda, and we just talk to them. And it's voluntary. They don't have to engage with us. And even when they don't want long-term support, they still engage with us. So we still offer advice and guidance.
Martin, can I ask, did this actually reduce readmission rates?
Readmission rates are massively reduced. Initial data stream, readmission rates were initially 35 to 45%. Our initial tranche had a readmission rate between 1 and 1.5% in line of sight. We're running long-term all-cause readmission is around about 8% for this service. The very worst functioning service for violence reduction in London runs an ED model, reduces admissions by half. The very worst model we can find in our practice. So it's incredible what kindness can do to change attitudes and narratives and outcomes. Hard outcomes can be changed by being kind. I think it's an important thing to recognise is that the support that the team that Roisin represents is an addition to great clinical care, in a great psychological care as well, and it's integrated. These are not people who are put on the side as epaulettes and peripheral service. The violence reduction team, this is integral to our trauma care. They get physical care, you get emotional care, you get social care, you get a violence reduction team, and you can't go home until all those services have been happy with you. We can't discharge you safely until Roisin or the guys are happy with your discharge. And our clinicians absolutely respect the work and the value that case managers bring to the patient's bedside. Our levels of expressed emotion, our levels of violence are reduced because of a team on the ward. The way in which we work has been transformed completely by being much more compassionate because we see the benefit of the work that Roisin and the guys have been doing. We are, for want of a better phrase, more trauma-informed, more culturally competent, but actually just more human. And we can be our authentic selves at work because we know that that's effective with young people who are in crisis. And more importantly, when the parents see that we care about their children, we physically and emotionally care about their children, not just care for their children, there's a real resonance there. And that fosters engagement. So the young people come back to their clinical appointments, they come back to their social appointments, and they come back and see us on the ward and say hello, and tell them what they're doing. And they engage with the police service on the ward because they trust the process. And it's earth-shattering to see a young person who was a victim of a violent incident, who has no reason to trust anybody, actively engaging with social care team, actively engaging with clinicians, actively engaging with police, and their parents supporting that. And then seeing that person come back to the ward months later saying, yeah, I'm out of that, living that life, I'm here, I'm doing what I'm doing, and not being transported 30 miles away to a new part of the world. They're living in situ with a real solution to their problems rather than running away from it. We've given up trying to export these kids to weird parts of the world to make them feel safe. That's not the way to treat a victim by exporting them into somewhere else. It's to bring that solution to their home, to make that home safe, make that life safe. So what we've done is we've transformed our care. We put the patient at the centre of our care, and we're delivering care that makes sense to that individual so they can buy into all of it rather than being prescribed care and prescribed support and prescribed behaviour. We say, what do you need and what can we support? And let's sense check that. And I think that's the reason why it's so important, because it doesn't just speak to what the patient needs, it speaks to what the healthcare needs to do to change. our system had to change, and this stimulus from this project has allowed us to grasp what good care looks like, what a positive outcome can look like, and what we can bring to a patient's table at the worst time in their lives. Rather than just patching people up, we can actually say, you know what, here's an opportunity for you to tell us a bit more about yourself, be your authentic self, and let's try and build a proper life for you.
Nikki, as a GP trainee, I'd really like to hear your thoughts on what you've heard so far.
I mean, it all sounds absolutely incredible, the work that you've done. I guess one of the main things that's jumping out at me, so I'm a GP trainee, and within that you work in different hospital departments and then out in primary care as well. And it does just feel as though the hospital is a completely different universe to the community. And as you mentioned, these walls around the hospital, which are physical walls, feel as though they're so much more than that. So how did you approach kind of breaking those down and bringing these services into both primary and secondary care?
I think, Nikki, it's a subtle change. I think it's about not worrying about the walls themselves. It's about bringing in a community to that space. So we're creating a hub of positivity within this space, okay? But that hub has got spokes going to the community. So there's always a place to connect to, and that positivity extends into the groups that work in the community. So our community team support those individuals as well. And the teams we allied with and we support with and we liaise with these young people have the same ethos, so we can communicate in that space. And because the care is designed to be realistic, it's not the ivory tower care that works in a hospital only. It's got to be built for the road, so it's got to be deliverable and be supportable. So if you build something, what we always find, if you try and deliver some ivory tower solution in a hospital that only works in a hospital, you take it at 2 o'clock, 8 p.m. and 10:30, and then you roll over to your left-hand side, and that works. That's not going to happen in the real world. But what's deliverable and road-tested here will work in that scenario, and that's why it's so important. We make sure that the care is robust and appropriate.
Roisin, this kind of model doesn't always work. Can you explain why it works in your context when it's failed in other places?
In a nutshell, we had buy-in from the clinical staff. We had Martin, who was leading on this, who had an understanding to some degree about what was needed and had recognised this. And I think, there's many cogs, isn't there, in a clock? And we're all cogs in a massive clock in what we call life. And I think all the cogs were in the right places, and staff were really keen for us, to work in partnership with them. And I think it was the right staff, the right support, and it was the right time. It was well overdue.
Much as I love the caseworkers we have in our program, I'm insistent that they leave, because this isn't just a piece of service you do for this hospital for a few years and move on. This is a process of development for yourself as well. And our case managers who've been through the program have gone on to some amazing things. Some of our case managers are now leading bigger processes. Rasheen herself came here saying, "Oh, I'm not sure if I should be a caseworker. I'm not sure I could do this sort of work." And now, 7 years later, she's running the entire program for London for her organisation. And that kind of development for me is really important. We're trying to make sure we support the development of authentic leadership within social care. So the individuals who work through this program, who work with us, they all go on to success, having been exposed to a powerful environment that supports their development and recognises their power. And I want to make sure that everybody who works with our system, be they victim, perpetrator, clinician, non-clinician, case manager, whatever, gains from the system, gains the ideas around it, gains the power to believe in themselves and does more with themselves afterwards. And the work we've seen the alumni of the program do since then has been fascinating. So we know that works. So everybody benefits from this service, not just the patients and their families, but the clinicians and the case managers. And that's the thing I'm most proud of. Once the individuals, the clinicians saw the power, the effect that the case managers had on those young people's behaviours, they bought into it body and soul. It wasn't about me selling it. It was a bit initially, but actually, once you see the evidence of Roisin and Antonio's work and Munir and Levine and all the other guys who've been there before, subsequently, you could see the impact that it made, and that engenders a huge sense of respect, because these guys could reach unreachable people.